I'm going to be talking about pneumonia. So, by definition, it's said to be an acute lower respiratory tract infection associated with fever, symptoms, and signs in the chest. Then there will be abnormality on the X-ray. The incidence is usually 5 to 11 per 100,000, and if higher, it can be higher if young or old. 30% are usually under 65 years. Mortality rate is about 21% in hospital. Classified into community acquired, primary or secondary, depending on the underlying cause. Organism that usually causes are the Streptococcus pneumoniae, which is the commonest, Haemophilus influenza, and Varicella catarrhalis. Atypical organism that cause pneumonia is the Mycoplasma pneumoniae, Staphylococcus aureus, Legionella species, and Chlamydia. Gram-negative bacilli like Coxella bonnetti anaerobes can be responsible if there is aspiration. Viruses can cause up to 15% of it, especially flu complicated by methicillin-resistant Staphylococcus aureus. Hospital-acquired pneumonia, defined as signs and symptoms greater than 48 hours after hospital admission. Mostly signs and symptoms that started greater than 48 hours after being admitted in hospital. Organism responsible is usually the gram-negative enterobacterium, Staph aureus, Pseudomonas, Klebsiella, Bacteroides, Clostridium. Immunocompromised patients like strep, the ones responsible in their home could be Streptococcus pneumoniae, Haemophilus influenza, Staphylococcus aureus, Varicella catarrhalis, Mycoplasma pneumoniae, gram-negative bacilli, Pneumocystis jirovecii, formerly called Pneumocystis carinii, fungi virus, cytomegalovirus, and episynclic virus, mycobacteria as well. The clinical features, symptoms could be fever, rigor, malaria, anorexia, dyspnea, cough, purulent sputum, hemoptysis, pleuritic pain. The signs include pyrexia, cyanosis, confusion, tachypnea, tachycardia, hypotension. Signs of consolidation is reduced expansion, dull percussion notes, tactile vocal pharyngitis, and vocal resonance, bronchial breathing, pleural rub. The signs and symptoms. So I've talked about the hospital-acquired pneumonia. I say that a patient admitted to hospital and feels the symptom 48 hours after hospital admission is called hospital-acquired pneumonia, and the organism responsible are the gram-negative enterobacteriaceae, Staph aureus, Pseudomonas, Klebsiella, Bacteroides, Clostridia. Immunocompromised patients include strep pneumo, H. influenza, Staph aureus, Varicella catarrhalis, Mycoplasma pneumoniae, gram-negative bacilli, Pneumocystis jirovecii, like I've said. And the symptoms that comes with this is the person has fever, rigor, malaria, anorexia, dyspnea, cough, purulent sputum, hemoptysis, pleuritic chest pain. While the signs are pyrexia, cyanosis, confusion, tachypnea, tachycardia, hypotension. Signs of consolidation: reduced expansion, dull percussion, tactile pharyngitis, vocal resonance, bronchial breathing, pleural rub. The test to be done, you do pulse oximeter or check the oxygen level, oxygen saturation level. Less than 92% suggests severe pneumonia. So that of the oxygen level, if it is less than 8 kilopascal too, suggests pneumonia, severe pneumonia. Blood test to be done, football count, serum electrolyte, urine creatinine, liver function test, C-reactive protein. The use of CRP to guide antibiotic prescribing, chest x-ray, lobar or multilobar infiltrate, cavitation, pleural effusion. Sputum to be done, sputum culture, microscopy and culture. Urine, check for Legionella, urine MCS, microscopic culture and sensitivity for Legionella, and mycoplasma, pneumococcal antigen. Other test is the polymerase chain reaction, BAL, and also serology. Fluid, pleural fluid can be aspirated and also studied, MCS. Then respiratory physician to be seen if bronchoscopy is needed or lavage. If you suspect that patient is immunocompromised or ITU. Someone listening to this can tell me about what ITU is. Thank you. So severity score we usually use could be confusion, abbreviated mental test score less than 8, urea greater than 7 millimole per liter, respiratory rate greater than 30 meter per 30 seconds per minute, BP less than 90 systolic or less than 60 diastolic, age greater than 65 years. The score and interpretation: 0 to 1, home treatment, hospital. It could be home treatment if you score 0 to 1, or your COP 65. If the score is greater than, if it's 2, you can be admitted into hospital, but if it is greater than 3, then you have to admit into intensive care unit. So ITU here now is just intensive care unit. Yes, I remember that. So consider intensive care unit if the patient is also young, which is the SCIBO, special care intensive baby unit. Then you have to use your clinical judgment. Management: give antibiotic. Local policy is that for mild pneumonia, the COP 65 is always less than 2 bar. While for severe, it's greater than 2 bar. Oxygen, if it's greater than equal to 94, just maintain oxygen level. If it's less than 94%, place the patient on oxygen. If IV fluid is needed, treat anorexia, dehydration and shock. Then give analgesia. Why you should put patients in intensive care unit: if there is shock, there is hypercapnia or hypoxia if it persists, and you can discharge to follow up at 6 weeks. There can be complications to this pneumonia. This includes pleural effusion, empyema, lung abscess, respiratory failure, septicemia, brain abscess, pericarditis, myocarditis, cholestatic jaundice. Repeat the C-reactive protein and chest x-ray. If no improvement, to check for progression or complication. Thank you.